a complete talk after various speakers this morning. So I'm here to talk about rural cancer care. Rural practices span states like Wyoming, Montana, South Dakota, Alaska, but there are rural practices in Washington State, New York, Pennsylvania. I want to take a moment to focus on this a bit more. 55% of Wyoming is defined as frontier. And frontier, rural, urban, suburban, and wilderness are terms intended to categorize a portion of the population continuum. Wilderness, of course, refers to the most extreme or remote end of the continuum. 46% of the land mass of the United States is frontier. And frontier means that there are less than 6 people per square mile. So I practice in a frontier location and have done so for 30 years. According to the census, recently 60 million people in the United States, or 20% of the population, lives in rural areas. Incidentally, broadband and internet access in these areas is very challenging. I'll get back to that. So what I hope to bring home to you is that frontier and rural practice is nothing like a suburban practice. And yet, most of the committees nationally, most of the cabinet positions, the upper level leadership representing rural patients is comprised of suburban doctors. And you are never going to have a solution for rural issues unless you have rural patients and physicians at the table. So 1/5 of the population currently in the United States lives in rural locations, and this fraction is expected to increase over time as many retirees move to rural locations. As depicted in this word cloud, there are a lot of charms to a rural location. But unfortunately, these charms elude most practitioners because only 5% of physician providers are in rural locations, and even a smaller percentage of specialists. Hopes that nurse practitioners and physicians' assistants would fill the gaps in rural communities have not been fulfilled. It turns out that nurse practitioners and PAs want to live in the same urban communities that GOs and MDs want to live and practice in. They want access to shopping malls, restaurants, subspecialty support. So the existing mismatch between provider availability and patient need is just going to increase over time. So social disparities in healthcare is a very sexy topic right now, but few people recognize or talk about the fact that rurality is a social disparity of healthcare. I defy you to try to find rurality on this word cloud that is a very popular internet word cloud. I guess I could offer a reward for someone who finds it on here. So the inferior health outcomes of rural patients with chronic diseases is well known, and it's been the subject of innumerable publications. These inferior outcomes have been attributed to provider shortages, to lack of access to screening services, to lack of health literacy by rural patients, to worse lifestyle factors like poor diet and more smoking, or to ill-defined geographic issues. I would like to point out that many rural places are kind of food deserts. We know about food deserts in cities, but we get the very worst produce in Rock Springs, Wyoming. If I buy cucumbers for the week, they are bad by 2 days afterwards, and I can't afford to go to the grocery store every day to get vegetables. So food deserts, keep that in mind. So these things that I've listed, however, are only part of the picture. I want to spend most of the time today kind of outlining other contributors to the inferior outcomes of rural patients. One thing that goes unnoticed that I want to stress is that these poor outcomes are going to get worse over time. Again, this familiar word cloud. There are many charms to living in a rural location, and many more retirees are returning to their rural roots. They like the slower pace of living. There are economic benefits to living in a rural location. They want to go back to where they were born and raised. But again, the providers are not moving to those rural locations. This, coupled with the declining numbers of doctors in general, is enhancing the supply and demand mismatch. Another factor that's less well recognized is the closure of rural healthcare facilities. This is in part due to provider shortages, but even more due to financial issues. Reimbursements are low. There's a high rate of uninsured patients, which often translates into uncollectible charity care. And for-profit insurance that's mandating out-of-hospital service that diverts revenue away from hospitals to private, often for-profit facilities. I'll get into this a little bit more later. Medicare Advantage, which has arcane rules. They require prior authorization for everything. And they have a rule that says if you have not appropriately gotten prior authorization, you cannot appeal a denial of payment. Now, those rules are new to most hospitals and billing departments that have dealt with traditional Medicare, where prior authorization is not required. So hospitals are going bankrupt because of uncollectible charges. All of these financial matters lead to the closure of rural hospitals and healthcare facilities. But there's a bigger issue. There's an unspoken national agenda. You hear it whispered in meetings. They want to close rural hospitals and turn them into triage and transport facilities. The stated rationale is that centralized care is both cheaper and better. And this may work for things like a heart attack, a stroke, cholecystitis, or major trauma. But most conditions require chronic care. And some conditions like renal failure and cancer require chronic invasive care. They don't lend themselves to remote telehealth or to that kind of transport for care. And don't forget, many retirees may be less able to drive. They may not have local family members available to drive them to their appointments. And they are in a group where they are more likely to have chronic diseases. So faced with the need to drive hundreds of miles on a regular basis for health care for a chronic condition, they will opt to forego care and die. This is certainly going to increase the mismatch in outcomes between rural and urban practices. So there's been a lot published about the differences in outcomes for chronic to kind of outline the experience of a patient in an urban practice and compare it to the patient in a rural practice. So I know a little bit about this because I have practiced in urban settings before. And I'm going to pick two cities where I practiced and lived, Philadelphia and Seattle. So if you look at this next slide, the left-hand panel depicts downtown Seattle. And the red balloons are cancer centers in downtown Seattle. Middle panel depicts downtown Philadelphia, and the red balloons depict the cancer centers. So what you can see is there's a huge choice of places where you can go for your cancer care, and they're all pretty close to one another. Most are less than 20 miles from your home. So even if you don't have a car or you can't drive because of your condition or its treatment, there's also public transportation available. You can take a taxi, you can Uber, you can take a bus, a subway, a train. Weather might slow you down a little bit, but it's unlikely to keep you from getting to your appointment for weeks at a time. And if your insurance or your temperament do not suit one of the healthcare facilities, you can switch to another healthcare facility. You may even be able to switch to another doctor within the same healthcare facility pretty easily. And while weather may make your ride longer, it's not going to make care impossible. You can probably get diagnostic tests before or after work and not miss a day of work. And if for some reason your mail order pharmacy doesn't ship you your chemo pills, you're likely to be able to get an emergency fill from a local CVS pharmacy. And the odds are great that your access to computers and the internet is not a challenge. Remember, rural and wilderness settings have trouble with their broadband and cellular service. Finally, we talked about clinical trials this morning. When you live in an urban center, you have a great deal of choice in clinical trials at various facilities. Cost of gas and wear and tear on your car. It's the opportunity cost of the time devoted to traveling for healthcare. And since most of these individuals don't have jobs that come with benefits, they don't have FMLA or paid leave for healthcare. So each day of travel for healthcare means a day of income lost. So what this translates into is that patients don't seek care for things that appear to be non-life-threatening. They delay care. So often by the time they're diagnosed, their stage is higher and less treatable. Once a patient goes to the doctor and gets diagnosed and is given a treatment plan, patients have to decide whether they can afford it, even if free lodging is provided. They may have access to only one costly imaging center, costly due to the lack of competition. Before I practiced in Wyoming, I practiced for 12 years in Idaho. In both of these locations, I've had patients tell me that they could get an imaging study for 1/10 the cost they were charged in our facility if they would drive to Salt Lake City. But that adds another 3 hours of driving to their time, so they don't often make the choice to go for a cheaper CAT scan because it costs them time and gas. So lack of competition increases the cost of care. And once they've committed to treatment, weather conditions often lead to road closures, repeatedly delaying care. So on the left, the yellow map is the state of Wyoming with the highways highlighted. The map on your right is, again, the cancer centers in Wyoming. So great distances involved. And the roads are frequently closed, not just because of weather, but this landslide happened last year. And it closed the road between Driggs, Idaho and Jackson Hole, Idaho. Now Jackson Hole is very expensive. People who work in Jackson Hole often live in northeastern Idaho, so their 60 to 90 minute commute became a 6-hour commute with this landslide. But the weather conditions that close the roads are commonplace occurrences. Last year I counted in 1/5 of the weekdays in the winter, the highways were closed due to wind, fog, snow. So when this happens, FedEx doesn't deliver, UPS doesn't deliver, even the rain and sleet and snow doesn't stop us. United States Postal Service doesn't deliver. So our patients don't get their chemotherapy drugs. We have even had food shortages because of these. Last year we had food shortages. I couldn't get half and half for my coffee, and I'm a big coffee fan, and I can't drink it without half and half. And these conditions are likely to get more frequent as the weather becomes more unpredictable due to climate change. We've talked about telemedicine at this meeting, and I think it's wonderful. And it's great for surveillance visits. It's not so good for cancer care when you're needing treatment. But many of my patients don't have access to a computer or a smartphone that enables them to do a televisit. Phone service shuts down, and that's not a rare occurrence. Just last month, I was on a meeting, an ASCO meeting, and I was speaking, and a transformer went out. So the power went out, the internet as a result of that went out, and in the middle of me answering a question, they got a black screen. And Dr. Robin Zahn, the head of ASCO, happened to be on that meeting, and I hear that she's been talking about it a lot. So an urban or a suburban doctor, that's not in their realm of experience to have the internet go out and impede their ability to communicate with their patients or other individuals. Some of my patients don't have the technological literacy to make signing up for the portal or possible for them, and that's the way we access telehealth services. I have lots of patients who will call me and say, I've been trying to log into my portal for the past 20 minutes, can't I just do a phone call with you? And I would like to say yes, And I used to say yes every time, and then the billing manager came to me to show me how much money I had lost the hospital because after the COVID epidemic or pandemic was over, they stopped telephone reimbursement. So during the COVID pandemic, they were allowing telephone visits and reimbursing for that, but they stopped it. So the billing manager came to show me how much money I had lost the hospital by being willing to let my patients call me. And even those phone calls can be in danger. That is a real message that I got at the hospital after the service was reestablished. So road closures, FedEx deliveries, and phone calls. Now I thought things were bad for my patients in Wyoming, and then I talked to a colleague in Alaska and heard that his patients kayak for a while, then they get into a car and drive for a while, and then they are flown to their clinic appointments. So my patients don't experience the most extreme conditions. Finally, there's one other matter that's kind of unique to rural patients. Health and longevity are often not their number one priority. Sometimes my patients miss their appointments because they're bringing in the beet harvest or the bean harvest, or they're rounding up their cattle. And when I ask them why they did this, they tell me they need to do it to generate the income to pay for their care and to pay for their lives. And after they've done this 3 or 4 times, they question whether treatment is even worth it. In the 10 years that I practiced in urban settings, I had urban patients withdraw from care, but they never withdrew from care because of inconvenience. So that's a factor that we have to remember when we're dealing with rural patients. And I hope this is bringing out the difference, the challenges that a rural patient experiences. I also want to stop and switch gears for a second and talk about transfusions. Patients in urban practices have access to platelet transfusions, irradiated blood products. In rural practices, you don't. The blood bank only keeps packed red blood cells. So if I want to give a patient platelets, I have to plan for 48 hours from now. And if the weather is bad, a state trooper from Rock Springs drives to the halfway point. A state trooper from Cheyenne, where the blood bank is, drives to the halfway point, and they exchange the products, and then each person goes back to their home. That's how we get blood transfusions for anything other than packed red blood cells in rural settings. So this is endangering 2 state troopers' lives to do this. And if the weather conditions are too extreme, even this is not possible. And remember, if the roads are closed, the conditions are probably too bad for airplanes or helicopters to transport patients who need a transfusion. So that means a patient dies because they couldn't get a transfusion. I don't think that's ever happened in an urban setting. You may not have the right blood type, but you will certainly not be without blood products for a patient in an emergency. So patients in rural settings die because they can't get their transfusion needs met. And before we leave the comparison, I want to talk about clinical trials. This is another passion of mine. Participation in clinical trials has been shown to improve patient outcomes. It's unknown whether this is because of standardization of care in a clinical trial setting, if it's because there are more people supervising or looking at the patient when they're in a clinical trial. It's not even known if it's something intrinsic to patients who are willing to participate in clinical trials. But it's been demonstrated many times that patients who receive care in a clinical trial setting have better outcomes. And while an urban patient may have access to all kinds of trials, a rural patient has very little real likelihood of being able to participate in a trial. And this shows because when you look at the demographic of patients in clinical trials, 20% of those patients are not rural. And that's the demographic of our nation. I laugh at myself now. I naively made being able to open clinical trials a condition of moving to the site where I'm practicing now. And we became the first independent clinical trial site in the state of Wyoming. But it turns out We only have the capacity to open one clinical trial a year. We don't have the infrastructure, the manpower, or the financial resources required to open clinical trials. And many clinical trials require that you promise to enroll at least 5 patients a year. I may see 50 new breast cancer patients every year, but I don't see enough of each stage and marker type of breast cancer to be able to promise to enroll 5 patients a year. So unless we change the system of clinical trials, something I'm involved with, rural patients are going to have to commit to further travel. They have to travel to Salt Lake City from my community to be able to participate in a trial. And it takes a very unique patient, a patient who's very health literate and understands the value of clinical trials and who has the financial ability to do the extra driving for a clinical trial. And that patient may not be representative of all rural patients. So it's not currently possible to get 20% of patient representation in clinical trials. And I think you guys heard from a question I asked this morning. Rural patients don't have access to palliative care services. They don't have access to hospice services in many locations. And the cost. I think we've talked about the fact that the cost is higher for rural patients, and rural patients often have a lower income than urban patients, so they can't accommodate that cost. So is it any wonder that rural patients have inferior outcomes compared to urban patients? So people are aware of the problem, and here are some solutions that are being worked on right now. There's a Washington State palliative care initiative that's trying to bring palliative care to patients. And on the right, there are efforts to bring molecular tumor boards to rural settings. But this is just a start, and I would like to call your attention to an editorial published in the Cancer Journal in the month of September about how to bring geriatric assessment to rural sites. I have some concrete suggestions for how to help fix the rural manpower and poor outcomes situation. I think we should concentrate on things that we can fix. So one is manpower. I never dreamed of working in a rural setting, but here I am 30 years later, still working in a rural setting. I would never have been exposed to the charms or the attractive challenges of a rural practice if serendipity hadn't brought me to one. But if I had had a 3-month mandatory rotation during medical school, residency, or fellowship, I might have found it was suitable for my personality or been exposed to the attractions earlier on. But since trainees often provide cheap labor for academic tertiary institutions, leaders at these institutions are unlikely to voluntarily allow their fellows and residents to rotate elsewhere. But trainees are largely subsidized by government funding. They pay for graduate medical education. So it's going to require some element of government coercion, do I dare say it, and or funding to achieve this. But the health of the entire nation is the responsibility of the entire nation. So we're going to have to step up and do it. As unlikely as it seems that's going to be possible. There's another manpower fix that I'm a little bit hesitant to say, but I don't think you have any rotten eggs or tomatoes. So we do loan forgiveness for people who promise to practice in rural locations. We give visas to foreign medical graduates who practice in rural locations. But usually the requirement is for like 3 years of service. You can hold your nose and do anything for 3 years. If we extended that period of time to 8 to 10 years, the trainees would be embedded, integrated into those rural communities and less likely to move away at the end of their loan repayment periods. Another manpower fix is to expand telehealth services. I'm talking about traditional video telehealth. So right now, urban centers are very attractive for subspecialists. They're often underutilized subspecialists in urban centers, while there are rural patients who have no access to subspecialists. If we made telehealth services easier, we'd have less of a mismatch. This requires 2 things. First, sustained funding for telehealth, and I think That's less in danger, but it was very easy during COVID, and a lot of us were exposed to telehealth. But another thing that happened during COVID was that we waived the requirements for licensing, state-to-state licensing. As soon as the COVID pandemic was deemed over, they stopped this. And my urban colleagues in Salt Lake City cite not having a Wyoming license as the reason they can't provide services to Wyoming patients. Why not allow national licensure for telehealth services? And, you know, apart from medical marijuana and abortion access, medical practices are pretty similar across the nation. If you wanted to, you could license everyone for telehealth across the nation, and you could exclude marijuana prescriptions and abortion services from that licensing. Credentialing is also a burden. Right now, credentialing is hospital to hospital, it's onerous, it's time consuming. I suggest national credentialing for the provision of telehealth services. And speaking of telehealth, we have to go back to providing reimbursement for phone medicine, especially in rural places, because rural places are where patients often don't have access to video or internet services. And since we recognize that care in a trial setting improves healthcare outcomes, and since clinical trials want to be representative of our entire community, not just urban patients, we have to facilitate efforts to improve rural patient access to clinical trials. This can be most easily achieved through centralized patient review. Someone asked a question about that, and centralized patient review is possible. And then decentralized trials. So one of my patients in Wyoming can have access to a trial that's only available in Houston, Texas, for example. Again, since there are financial and regulatory issues involved in trials, the solution to this is going to require some government coercion or funding. So we need to encourage decentralized or hub-and-spoke trials. Finally, healthcare in this country is still a for-profit business, and I think that's a problem, but it will remain so for a while, and we don't have universal healthcare in this nation. So if we want to keep hospitals open, we have to help hospitals maintain the level of funding that supports their existence. We have to stop private equity cherry-picking the most financially healthy institutions, robbing them of their equipment, draining them, let me say, not robbing, draining them of their equipment and assets, and then after 3 or 4 years, abandoning the hospital and the community that was served by that hospital. Sometimes the hospital is the only access to health care rural patients have. In many of the settings, so when the hospital disappears, there's no health care. I just want to bring that home. We have to be aware of the dangers of for-profit insurance companies that endanger the financial solvency of rural institutions by coercing them to divert any profit-generating business to an outside, I should call it revenue-generating business, to an outside for-profit facility. That leaves the hospital with only the revenue-losing patients, charity patients, Medicare, Medicaid patients, and no institution can operate if they're losing money over the long term. We have to recognize that Medicare Advantage in many states is a Trojan horse that is diverting funds away from hospitals and bankrupting them. Just recently, there have been stories about Medicare Advantage charging the Veterans Administration $1 billion and not providing any services for that money. We all pay for that. So, I hope that you can appreciate some of the unique challenges that rural patients face and why perhaps rural chronic disease outcomes are worse than urban outcomes. So the final thing I want to talk about is why I do it. Because I'm a city girl, I have offers for urban jobs all the time. I never anticipated being a frontier physician like, who is that, Jane Seymour. The reasons are really 3 or 4. First and foremost, medicine in rural practices is still very relationship-based. So My patients are loyal, they respect me, and that means a lot to me. When I go to the grocery store, the daughter of a patient will talk to me. I'll go to an art show, and a patient I treated 5 years ago will be there to tell me about what they've accomplished in the 5 years since they were my patient. In general, litigation rates are lower. This may be because we have relationships with our patients. It may be because the state recognizes that litigation will drive the skeletal supply of doctors out of town. And thinking back to that word cloud, I appreciate not having to stand in line, not having to pay for parking or circle the block 8 times looking for a parking spot. Yesterday, I nearly missed my plane because they changed the flight time. And the TSA agents all ran to help me make it. I came without a suitcase. I put my outfit in my briefcase. But they wouldn't, I don't think a city TSA would have done that for a doctor who was late for their plane. But most importantly, I think if you like a challenge, the challenge of being capable, if not excellent, at multi-disease management, the challenge of developing relationships with subspecialists who do treat one disease and who are willing to support you. If you like that kind of a challenge, a rural practice is good for you. My last comment is that rural medicine is in danger, but rural medicine is the canary in the mine. If we can fix rural access issues now, the problem with urban healthcare in 10 years will be solved. This was a Kevin MD podcast I did about this very thing, in case you're interested in watching. I want to thank Lacey Reddick, who's our clinical trials facilitator, but also a whiz with slides. And I'm happy to answer questions, entertain comments, whatever. I'll be insulted if no one has a question.
Thank you very much for this great talk. I just will add one little thing to your talk. I think we live in a society where the academia, independent practices, and hospitals all need to exist and collaborate with each other to have the healthcare system to work perfectly. So it's not one or the other. I just wanted to make that comment, add it to your beautiful thing. And just if we go away and independent practice is all closed, and then we lose the hospitals, who's going to take care of those patients? Academia will try, just not enough access to care. It's going to get worse.
I agree with you. I agree with you completely. I think that we're headed for a crash as a healthcare system, and it's only we're going to have to dig deep to fix it. But I don't think people are willing. And I think patients in urban facilities are somewhat shielded from. One hospital closes, but you have 6 others to go to. It's only after 5 of them close and your wait time, appointment time, wait gets longer that you notice something is going on. So yes, I totally agree.
I want to thank you for your talk. As somebody from East Helena, Montana, I have to tell you that that's not a big city. It's a suburb of Helena. But my relatives, when they were diagnosed with cancer, had a similar experience to what you're talking about. The roads closing and having to try to figure out in the middle of winter. But also, I was wondering, I work at Fred Hutch now, so I'm in the urban side. But what about nursing and kind of building up a regional nurse force with the community support of that? Do you have any ideas on how we might build that out?
Yeah, you know, I don't, and we suffer. I'll go back. Sorry, we suffer from nursing shortages. 40% of the nurses at our hospital are travelers, and they cost more. So I think these are all signs that our healthcare system is heading for a crash. And someone, when I was talking to them about this talk, they said, how come you're not highlighting what rural communities could do to attract providers? And I guess maybe I should mention that, but they don't. It hasn't worked for hundreds of years, so I don't know what they're going to do.
Another question? What percentage of your population has access to broadband internet, and is that changing? Is it improving at all? Decreasing?
I can't answer the question as a percentage, and I think a large number of the patients, the 500,000, 480,000 in Wyoming have some access. It's just that it crashes regularly. I support Wyoming Public Radio, but 3 months last year that they didn't broadcast. And so it's more of the instability, and maybe we need to invest in, I'm not a technical person, but what are those wires that are going to make it better?
Elon Musk and his Starlink network.
Yes, Elon Musk was going to get out the rural vote, and the broadband and internet problems impeded his ability to get out the vote. It didn't matter in the end, but he did comment on how frustrated he was. And I do want to mention what I asked as a question. It hurt me so badly when I promised a patient that I would make sure his death was painless, and found out that his community didn't have hospice services. And then I found out the next day that he was dead, and I did not expect him to die in a day. So I suspect he took matters into his own hands. But no patient in this country should die without access to hospice services, I think. Sorry.
I really appreciated your comment about interstate licensure. It isn't just for rural communities that it's a problem, it's those of us with rare cancers. As precision medicine moves on and we divide up our cancers into more and more smaller pieces, there may be only 1 or 2 people in the country that are experts in that type of cancer. And you can get through the initial treatment based on what's in the NCCN guidelines, but when you progress, you need to talk to an expert. And without that interstate licensure, we can't do it.
Okay, well, thank you very much for the opportunity. Oh, do you have a question?
So as Starlink technology starts coming out, it is not an accessible thing for a single individual. Is there any sort of thought process about a rural community coming together to invest in one as their own community that maybe could be used for medical services or other things that are important enough that if the landlines were to be taken down, having access to that sort of thing would be of assistance?
I have to think of a politically correct way to answer that question. Remember, these are poor communities in general, and until they have a need, they may not recognize the benefit of having it. How's that for an answer that's relatively... Thank you.